Right. Good, good morning. It is March 13th.
February.
House Healthcare. Sorry. Thank you everyone for your patience today. We're gonna need it. And Legislative Council is here with us and we're gonna walk through some changes to H585.
Great. Good morning, Jen Kirby, Office of Legislative Counsel. So we're looking at 585. I've incorporated all of the changes from the last draft and done markup for new or revised provisions.
Yeah, can I interrupt you really quickly? Just, I'm not sure, what time do we have you till? I know you've got a lot of.
Arguably 10 o'clock, but I'm supposed to go down sooner if you're done soon with this one.
Thanks.
The fairly minimal number of changes in this draft. The first is in section 1 in the health insurer governance sections. And after discussion with the chair, at least for this draft, we've maintained, so I highlighted it but not bold, that the governor would appoint the 2 representatives of the public. I don't know if you want to say anything more on that.
I will just say that after discussions with Department of Financial Regulation, we were having back and forth about, well, maybe the legislature should have a say or somebody else should have a say. It would require creating a whole apparatus around similar to the nominating committee for the Green Mountain Care Board, which would mean people would have to be named to the nominating committee and then they would have to, and it just seemed like a lot of work, not much bang for the buck, I guess is what I wanted to say. So I'm just putting it back out there the way that it originally came to us. That's all.
All right. Then nothing changes in next few sections until we get to association health plans. So the sections on association health plans themselves are unchanged, but the effective date is delayed 2 years with a report here coming back to you on what I call the federal landscape. This would have by January 15th of next year, DFR report to this committee and the Senate committees on the status of federal law regarding association health plans, including the extent to which federal law would allow for the expanded access to association health plans permitted beginning January 1st, 2028, pursuant to the changes in sections 3 and 4 of the Act. So basically, based on what you had heard, I think from DFR and others, that federal law currently would not permit a more expanded use of association health plans. This would delay implementation in Vermont for until 2028 with a report back in 2027 on whether things have changed at the federal level. And then I've just renumbered the remaining sections. So you'll see all the stuff that was struck in the last draft is gone from this one. We've got the site neutral billing for physical therapy in here. We've got the removal of the prescription drug specific out-of-pocket maximum language in here. Got the health care sharing plans language in here, and no changes to any of those except section numbers. And then in the effective date section, I have carved out the association health plan changes to take effect on January 1st, 2028, consistent with that report back. And that's it.
Can we go back to the association health plans section? So we have all the same language that they may do all of this, but then we just delay it and added that they have to report back. So that means that if they report back, would we then have to repeal what's in section 3 that we're putting in there?
Only if we wanted to keep the narrower scope of association health plans in Vermont, regardless of what happens at the federal level.
So if we do nothing, then they can move forward with.
Right, so if you set up the expanded access to association health plans for 2028, and the report comes back in 2027 and says whatever it says, if you're okay moving forward with expanded access to association health plans as soon as the federal law allows, then you make no changes. If the report comes back and says it's permitted under federal law, and you decide we don't want to allow expanded access in Vermont, you would need to make changes at that point.
Go ahead, Dawn.
So, and I apologize, because I don't think I was in here the last time we talked about this. So, but the language in here doesn't also require anyone to study the effects of association health plans.
No, it just
On-
expands the access.
Okay, thank you.
Yeah, it provides the expanded access. And I do want to know I think there may be some conforming changes I need to make on the prescription drug out-of-pocket language. Just there's some references in other statutes, and there's a separate statute allowing for bronze plans to be developed in a way that has some exceptions from the otherwise applicable limit that I think I would need to go through and clean up.
Thanks for mentioning that. So currently, in current law, we have this language that is being struck through.
We're talking
But we have.
drug out-of-pocket?
Yeah, the prescription drug out of pocket. But we then have in other places a carve out where bronze plans can be developed.
Yes, it is my recollection and understanding from several years back that the prescription drug out-of-pocket maximum that is in what is now ABSA 4092 created plan design challenges for the carriers creating bronze plans in the qualified health plan market because of the 60% actuarial value, plus or minus a little bit, that they have to meet. And so in order to design plans that had a little bit more flexibility, just pull up the statute on that, a little bit of a carve out or exception language was provided. So maximum out-of-pocket limit for prescription drugs and bronze. All right, let me put this up. So it is, if anyone's curious, 33 VSA 1814. And that language says, notwithstanding any provision of ABSA 4092, which is where that prescription drug limit is, to the contrary, the board may approve modifications to the out-of-pocket prescription drug limit established in that section for one or more bronze plans, as long as the board finds that offering those plans will not adversely impact the plan options available to consumers with high prescription drug needs who benefit from that out-of-pocket prescription drug limit. It requires the DVA to certify at least 2 standard bronze level plans that include the out-of-pocket prescription drug limit in that statute, as long as they comply with federal requirements. And then notwithstanding that limit, the department may certify 1 or more bronze level qualified health plans with modifications to the prescription drug limit, out-of-pocket prescription drug limit. And then there's some language about kind of auto re-enrollment, trying not to adversely affect someone who was relying on that lower out-of-pocket drug limit. Providing some re-enrollment language there.
Brian and then Daisy. I had a question.
I feel bad admitting this, but I really am struggling with understanding all of
That's
this.
what I was thinking.
Okay, and I want to be honest because like I read it and you're explaining it and I'm still having a hard time understanding how it all works and what the bill's doing, because we got this letter saying they're concerned about it making prescription drugs not affordable, and I want to be able to explain to people how it's helping and not hurting things. So I don't know if there's any way you could, in like 3rd grade language, or maybe I can ask AI to do it, but like somehow like
I wouldn't.
tell us,
Kind of question.
whatever will help. Yes. Yeah.
That might address some. So let's say instead of doing what we've done in this bill, striking out that language, what would it take to allow insurers to develop plans across the metal spectrum. Would we repeal this or would we add to the section of statute that you just read that says you may develop? So like, what if?
Right, yes, I think you could take out this specification for bronze plans in that carve out language and potentially authorize more, plans at any metal level that vary from the 4092 language while requiring that some number continue to meet that.
So would we keep the existing statute that we're striking out in, that's added to 585? Would we keep that if we wanted to require that insurers develop, that they have plans that have this cap? And then would we go into the other section of statute and say, you may develop plans of any metal level that don't adhere to it, but that you have to maintain the ones that are currently there?
I mean, I think there's different ways to approach drafting it, but considering we're only talking about qualified health plans having greater flexibility, I think it would probably make sense to modify the statute that's currently only applicable to bronze plans.
Okay. Easy.
I'm still not crystal clear, and I want to be. So right now, and Jen and I have had a little bit of back and forth, and I really appreciated that through email. Right now, we have, Jen, correct me if I'm wrong, we have a max out of pocket for prescription drugs and then separately for medical.
So right now we
In the
have
fed
the
way.
federal level, the federal law under the ACA sets a maximum combined out of pocket. And I am not the expert on this, so you may want to hear from Diva that it does this for the carriers. But it's my understanding that the federal maximum out of pocket does not for the most part distinguish between medical and prescription drug. It's generally a combined maximum out of pocket. Vermont law specifies a prescription drug maximum out of pocket, which by definition establishes, or by its existence establishes then a medical maximum out of pocket, because it's the difference between the federal total out of pocket and the prescription drug maximum out of pocket. So yes, right now you have, and I'm trying to actually pull up, I think you had testimony on your website yesterday,
Right.
And
recently from
Yeah.
Diva that gave you the numbers, because otherwise I have to look them up. Hold on.
so Jen, the removal of the prescription drug cap does not change the overall max, but it would mostly impact people who have high prescription drug costs, because now that cap potentially is removed, but it would potentially benefit. And is this the intent, is allowing flexibility for the plans to create across the metals plans that would accommodate people that have higher medical costs. So like if you were going to get heart surgery and then, your follow-up medication is aspirin, it's not, cancer medication or something. I'm just trying to think the real world, like who is this? benefiting?
So again, based on my understanding and my recollection of some of the conversation when the bronze carve out was done, is that some people have high prescription drug out of pocket, had high prescription drug needs, and having this statutory limit is very helpful. Other people have higher medical non-prescription drug needs, and having the higher out of pocket across plans for those people is less helpful for them, because they don't get the benefit of the lower cap on the prescription drug costs, because they don't have prescription drug costs that hit that cap. So a potential benefit would be to create greater flexibility in plan design that could meet different Vermonters' needs. What the impact would be on individuals and what the impact would be on plan offerings and the costs for the plans, I don't know.
Leslie, but I just wanted to say, I just sent Tasha Vermont Health Connect has like a rate sheet with every single plan that's offered. And it breaks down, and I've asked her to print on large paper because it's really tiny writing on it. So we'll have Tony down and printing just so that people have, so that they kind of know what we're talking about here. So we'll get that, but that'll take a little while. Leslie.
So I was just struck by what you said about not knowing the impact on the individual or the system as a whole. So do we have enough information, or do we need some actuarial help in understanding?
I think we're gonna hear from Blue Cross Blue Shield, who has done some
Okay.
analysis around this.
I'm a little curious.
Okay.
Yeah.
Yes, so just for informational purposes, and you'll probably see this when you get the sheet as well. Because of the way the language in the existing prescription drug maximum out-of-pocket is framed as being the minimum deductible for which a plan qualifies as a high deductible plan under federal law, which is really just a way of pegging an index. That number is currently, so the current prescription drug maximum out-of-pocket in Vermont is $1,700 for self-only coverage and $3,400 for family coverage. The overall maximum out-of-pocket from the federal law is $10,600 for individual and $21,200 for family coverage. So to put those in context, and I'm not going to try to do the math, but the overall overall maximum out-of-pocket is $10,600 for an individual, of which $1,700 is their prescription drug cap, and the difference there, which I think is $8,900, is their medical out-of-pocket max. Similarly, for family coverage, the 2026 maximum out-of-pocket is $21,200 for family coverage, of which $3,400 is the prescription drug maximum out-of-pocket, and the rest is medical.
So, does everyone understand that? Okay. Oh, good, the healthcare, because I was thinking, where's the healthcare advocate when we need him to testify?
Can you just take us back to why we're talking about the bronze plans right now in relationship to this?
So we're not really specifically talking about bronze plans, except the fact that there has already been a change in Vermont law affecting bronze plans because of the pressures that this prescription drug out-of-pocket maximum places on plan design for a bronze plan that has to have a 60% actuarial value, meaning that the patient is responsible on average for 40% out-of-pocket.
Okay. Brian?
So this may not be the best question for you, but I'm gonna ask it because you might at least give us the legal explanation, but it might be better for the healthcare advocate or someone, but I'm trying to conceptualize. I'm not asking you to explain to me again how it all works. I need to read it and digest it. But what I'm getting is that we're playing with variables in an equation and changing the variables. And I truly believe the intent of everyone involved is to make things better for people. But I'm really concerned are who are going to be the winners and losers, because in every decision we make, there's inevitably winners and losers. And I'm wondering like how this is going to play out for people. Like, are there going to be certain individuals who suddenly are spending a lot more than others? And it's hard because sometimes we have to make a choice in that regard, but I'm really struggling with understanding how it's going to affect people. Like, for example, you mentioned the different numbers being caps on different kinds of services. If someone goes over their prescription drug cap on prescription drugs, does that not count to their overall deductible?
Oh, it does. Don't think about the cost accumulator stuff.
Okay.
This is really, at what point does the insurance pay 100% and the patient is done paying out of pocket?
So, okay, that was actually a very helpful, clear thing you just said. Because now I'm imagining a person like going to the doctor and they have a health condition, they're racking up bills, and the insurance company is barely paying because they have a deductible or not paying. Not to be disrespectful to anyone by that, but it's just how it works. Like they don't pay until a certain threshold. So like they're not paying. So this person's like struggling, like trying to figure out how they're going to pay this medical bill. And then, and so they hit their prescription drug cap first. Now the insurance company's paying all the prescription drug.
Yeah.
But then they are still responsible for the rest of their deductible.
Right.
Up to a certain point, and then the insurance kicks in. But if they,
Right, but we're also talking about deductible versus maximum out of pocket, so those.
yeah, this is what I'm, yeah, so this is why it's so
Those are all-
confusing, yeah.
Yeah.
But we don't need to keep going with it. I'm getting a better sense of how it's this complicated equation and how for each person, depending on their situation, it's gonna play out differently. And I guess my ultimate question is, who are the winners and losers here?
Right, and you'll see if you look at Addie Stromolo's testimony that she submitted yesterday, Diva says it is willing to study the impact and that it would take actuaries to assess what a change would mean for the QHBs.
Okay.
Which also
I didn't
means.
see that yet.
don't
Thank
ask
you.
Nola. Okay,
Yeah.
I just said, don't ask you. It's an actuary question.
Okay. Any other questions? I know there's lots of questions.
You're saying that Addie's testimony is on our website.
Was from yesterday, I believe. It
I'm
may
looking
even
at
be posted again
Tuesday.
today. Oh, it's posted today.
Okay,
Look at today.
I looked at the wrong day. Okay, great.
I think it was yesterday too, because I read it yesterday.
Any other questions for Jen? Lori, did you have another question on the AHP?
Yeah, I'm wondering if since we're putting in this language that says report back in 27, right? So do it in 28. I feel like when we've had the testimony on AHPs, there's been no information from the administration that shows that what the effects would be, like to the market, to plans, businesses, would it actually be cheaper or not? I don't have like in my mind what the language would be, but I'm wondering if
Thinking
we
adding
we
that to
can
the
add
report.
something in that makes them have to come back and prove this is actually gonna work and not be a detriment to other people. So I can't help with language, but I'd be interested in.
And then
Lori,
Brian?
could you explain what you mean by if this is actually gonna work? When you just said that.
So I think the administration came in and said, and businesses too have said, we need the association health plans because businesses need a plan that's cheaper that we can afford. Totally support that, right? Businesses, especially small businesses, it's really, really difficult. But there's no data that shows it actually would provide cheaper plans, right? I mean, it's been a long time since we've had association health plans, and a lot has happened with our health insurance market since then. And there's been nothing that shows what the effect would be on the individual market if we start pulling more people out. And so since we're not putting it in place right away, can we have the administration come back in 27 as part of this other report to really talk about the effects of what association plans would be to businesses and individuals and the market at large?
Okay, and just in common, this is my own opinion, just common sense. If you bring together, for instance, the Chamber of Commerce, all the businesses, and you then apply, let's bring it all the way down. You get the okay to have an association plan. You formed an association. You didn't do it just for the insurance, but insurance is part of it. I cannot believe that it wouldn't be cheaper for those people that work in those businesses. In the business.
Right, and so probably, but to what extent? Is it gonna be cheaper by 1% or 2%? But yet individuals are gonna go up 20%? So think about when we did the individual and merged and unmerged, right? Like, we didn't just say we're gonna do it. We knew that if we separated, it was going to be a 17%, I might be off my numbers.
Yeah.
Increase for individual, or 7% increase for individuals and a 17% decrease for businesses, right? We knew that. And we could make an intelligent decision on what to do. Plus we had the subsidies on the individual side, so it made sense. Like, I'm just looking for that same type of analysis behind this very important move that I really want to support. Because I want to support our businesses, but right now I can't.
And I see you, Daisy, and I wanted to add to that is, I'm not only what is it gonna do to the rest of the market? There's this assumption that these plans will be cheaper. But do we know that? Has anyone looked at it?
Well, anytime, in my opinion, anytime that we ever did that, when did the prices to individuals go up?
Yeah.
When?
When we unmerge the market to help the small businesses. Yeah.
We're talking about.
So now we're talking about even unmerging it more, really, quite frankly,
Without an analysis.
without an analysis.
Which I'm concerned that it will destabilize the small group
Yeah.
market we've tried to stabilize over it. And the other things that, and I keep asking this question, and people have actually come to me and said this, some representatives and senators, frankly. I'm not even sure if we know, if you have an association health plan, you have a administrator of that plan, the underwriter, the insurance company that underwrites it. We're not even sure who would be underwriting the plans. And I'm a little concerned about some of the companies that do underwrite these plans, that we don't know what their reimbursements are and their contracts. And I mean, I know one insurance company that tends to underwrite a lot of associated health plans. And it's the same insurance company that we've received lots of written testimony from before, that frankly doesn't pay nearly enough for mental health services, physical therapy services, and that there's no negotiating power for providers to actually negotiate with them. And I'm worried about adding on to already the burden that our qualified health plans, because we do regulate them and we regulate the rates of hospitals, that we're putting even more of a cost shift onto our QHP plans because we don't regulate the costs for the third-party administrators or the underwriters of association plans. And I'm not saying that that's true. I mean, I'm just making an educated guess. It might not even be an educated guess, but the point is we don't know. And I just feel like we should look at all of these issues before we jump full in. Go ahead.
Yeah, I don't know if what I'm gonna say is that different, but it's maybe simpler, which is like, my concern is that we already have a limited demographics, like we have this limited population, and even if we unified all Vermonters, we'd have a 600,000 person risk pool. So every time we divide people to different plans or different insurance carriers, it's different risk pools. So when we merged the market, it was it's larger risk pool. We unmerged it, and that caused the individual to go up, but the benefit of the businesses dropping was worth it because the individuals got the subsidies. But now we're talking about pulling more people possibly out of the group. That's going to shrink that risk pool in an already limited environment. And that to me would make me concerned that the prices will go up, but we don't know that. And so I think what I would support would be like further analysis of this, and then us having numbers, and then we can look at those numbers and we can make an educated choice. Do we want to do this? And it's not always exact, but it's projections. And so the projection might say, that it's not going to have a big impact, or it might have an unintended impact, but I'd rather us not not gamble on it. And I feel like I learned the hard way because we went through this once before. But, I'd rather us just merge everyone. And I think everyone knows that, but so I feel like unmerging people more is it's risky. If it made sense in this current system, I would support it. I'm just nervous too. That's all.
What do you got in your hand?
Oh, this is a different thing. You can look at this if you want. I'm just holding this right now. Yeah, this was about the prescription drug thing, and it's just in my hand. It's like a comfort item right now. So, you know, I can hold the zebra
I
instead.
thought you had something else.
No. There's no analysis. So that's something there.
Daisy had a question. So,
Yeah. I just was in my hand
I'm
stuff.
sorry.
No, it's been said.
Oh, okay.
I guess my final point is just, we're already pushing it a year, right? So let's add an analysis behind it. I will say, even pushing it a year, I can't support it like it is right now without having additional data to be able to understand the impacts, good and bad.
When you say the way it is now,
And that it would just go into effect. There's no analysis.
we're talking about this
Yeah,
new draft, you can't support this new one.
that section.
We're only talking about the association health plan.
We're just talking
Yeah,
about the association help us.
Well, how about if we're gonna do something like that? How about if we also do an analysis of pool and we find out approximately how many people may be left in the pool and do what we did with Catamount Health and subsidize the pool, then nobody gets hurt.
Oh, I thought we were all getting one.
Right over the place.
No, it didn't. I'm processing.
What you said, except I heard Catamount Health.
I was wondering, can we subsidize the group market?
I was just.
Yeah, that's what I was wondering.
Oh, we did it. Catamount.
That's why I was being quiet. I was thinking, that's what I was thinking.
Okay, so we have, when we talk about subsidizing the market, all I'm thinking about is the Vermont Premium Assistance.
Right.
And I don't believe we can subsidize the small group market. We can only subsidize the individual market. Oh.
No, for the record, no line with the joint fiscal office. You can subsidize whatever you want with general fund.
Oh, that's the,
Thanks for-
Yeah,
thanks for
yeah.
bringing us down.
where does it come from? though?
You can't use Medicaid dollars to subsidize small group or the individual market is certain people of certain FPLs. And the only reason we got away with it is because it was kind of piggybacking off Catamount, which was also an individual market thing. I would also say that I think any kind of thing that we do would require a CMS waiver, which we are unlikely to get in this environment, especially as we go into renegotiating global commitment in the very near future.
Right, that was gonna be my point, is I don't know the extent to which we can subsidize the group markets. I just use small group market. We'd have to look into that. So I don't want to declaratively say, yes, if you use general fund, it's fine. I don't know.
Brian,
We could find out.
Yeah, so I just want to make sure I understand what I heard, that we could, if we could subsidize what we want with the general fund. However, there might be a barrier for subsidizing the exchange because of our agreement with the federal government.
We reframe it.
Okay.
Jen just kind of corrected me and said she'd have to do a little research to find out if we could even subsidize the small group market, just to ensure that we're not violating.
I just don't know. We have never talked about it. I have
Right,
no,
so, okay,
I have no awareness under the Affordable Care Act with the way premiums have to be developed, whether there is an avenue. I mean, we added Vermont Premium Assistance on top of the federal premium tax credit and cost sharing subsidy assistance that is specific to the individual market. I don't know what our authority is around the small group market.
And I think I
So
just
we
said
would-
it because I was just trying to make the point that we can't get Medicaid.
Yes,
I shouldn't have said the general fund piece, but I'm trying to make the point that we will, unlikely.
adding an additional caveat.
Correct.
unlikely to what?
I was just adding an additional caveat.
Okay,
Yeah,
all right.
So, we just heard that we need to study the association plan, the way it was set up. So what I just heard here is we need to study this and see if we can do it.
So
That's all I was
that was about a separate question about providing subsidies to the small group market.
Right.
go ahead.
You're looking at me, but I don't know if it was like a don't talk or talk. Probably both. So I'm wondering, like, if a compromise would be to replace any action with association health plans with some kind of study that includes an analysis of the impact of these policy changes on the overall market and the potential ways that we, the potential federal barriers or opportunities in terms of the Affordable Care Act and subsidies. And then I would also suggest a third thing, which would be what might be income sources to fund those subsidies, because it would be nice to get some ideas and not us be just like making things up. Because I know what I would want to do, which is tax the wealthiest people and use it. But like, there might be another way that we can do it. So it should be analyzed and we should have all the choices on the table. That's one thought about the things we need to study and I would support some kind of analysis like that.
Okay, this is,
Okay, sorry.
Karen? See?
You just noticed.
You just noticed?
Oh my God.
I guess my question is, when you talk about subsidizing small business, are you talking about with the association that you would subsidize that?
No,
No, the small group that's in the marketplace. Another question I have, allow me to do my thought process here. So if this were to pass right now as it is, then we would, the associations cannot form yet, right?
Well, they can't form yet anyways because of federal law.
Correct. But it looks like it's probably headed that way.
Well, I think that DFR testified that it's not on their agenda for the
Okay.
next year. So,
But if we were to pass this, we're doing is, I get the study part of it, I get the delay, the start date, but that would make it a real thing, correct?
if we added the report and then we took action when the report comes back to make a final decision on not doing it, then we would have to change it. If we made no decision, or if we made no decision once getting the report back, then it would be allowed if the federal government has subsequently done that. I have Lori.
And me and,
Yeah, oh, no one's over there. Oh, no.
I don't want to cut in line.
Well, I know. For some reason, you're out of my peripheral
Yeah,
vision
sorry.
today.
I should have worn some black and purple.
You confused.
All I will do at this office. Well, I think a study will cost you money because it's actuary analysis. So you will need an appropriation. You will just need to say who's doing the study, whether it's DFR, but they will have to hire actuaries and you need money.
Now, DFR, in their charge, their purview, aren't they supposed to be doing this anyways with insurances? Isn't that part of their regulation? Is to examine actuarial pricing and things like that? And
So what they do, and I would defer to Kai on this, but they, as part of the regulatory process, sure, they have actuaries that review rates. They use bill back, I believe. This is sort of outside of that. You're asking them to do a study that I'm not sure they can bill back for. Maybe they can, maybe they can't. This is something that I would defer to them in terms of that process.
Which study are you talking about? Both
Well,
things on the table?
I'm only thinking, I've only been half listening, so I'm thinking about the review of the association health plan.
yeah, so I would say, yes, the one about, the initial one you're talking about the impact on premiums for plans in the market is gonna be an actuarial analysis that will require the use of their contracted actuaries. And I think Nolan's right that you would need to hear from them about what they, what is within their existing contract and what they would need additional resources for.
Yeah.
don't we have an expectation if DFR is coming to us with a proposal that they actually have information to back up the proposal?
You have not asked them to do an actuarial analysis of the impact on premiums in the individual and small group market until a few minutes ago. So I don't expect that they would have budgeted for that.
The follow-up, I'll just say, I'll look into it, but I'm flagging it as a potential cost. I'm not saying there's absolute cost, but I think there's definitely a potential cost to be more.
Good to know. I have Leslie. Hold on, I got Leslie Topper. Leslie, Wendy, Karen, Topper, Leslie, go ahead.
I'm listening to the conversation. It's really complicated, to try and understand. But it was gonna be hard for me to support, I guess we're talking about section 5 without, with a date in there for implementation. Because I think we need the information before I can imagine supporting a date. So that's what's hard for me. I mean, I understand it's gonna cost money, but how else do you do it? I think we really need the analysis. And then at some point, we decide about going, future with a implementation date, but I can't support it with a date already in.
Can I ask a follow-up to your question and Lori as well? And what I'm hearing from both of you is that you would support if the language was struck from the original bill and it was just basically the report back next year to say, here's the information, and then we essentially copy and paste this language from this year and put it into next year. Is that what I'm hearing, or?
I'm
you
okay
okay
with the language as is. I just want the additional data in the report to come back next year for whoever's sitting in these seats to review it.
And I guess I'm not that, because the effective date implies that regardless of what information we get, it would be implemented. And I'm having a hard time with that.
It's like a reverse sunset.
Yeah, it's about protecting the QHPs for me. And until we know that status, I can't support it because you're implementing it.
Is there a way to sort of write in that this only goes into effect pending legislative approval?
There isn't, I mean, your way of approving is to pass a bill.
Okay, I have Karen.
So I think of the way this statute is operating as sort of like a springing mechanism, like you might have in a trust or something. And so until we have the condition precedent of the federal government changing something we don't know they're going to change yet, it doesn't even exist. It's all theoretical construct. And I really love the idea of expanding options and reducing the cost of healthcare and making it more accessible for more people and for everybody. But as we know, because of the federal reductions already, people that used to be able to afford their health plans better are now less able to, or they got rid of their insurance. So there's already, with the subsidies going away, real impact on those folks. And if we have a mechanism that calls even more people off, I think I've heard some other folks say this, and you go, well, what happens to that tinier pool that's left, and how does that impact them? So I think we do need to understand the impact. I always want to not have unintended consequences on thoughtful legislation, and but still loving the goal of options and cost reduction and all that. It seems too soon before we even know if the federal government will allow it. But if we have the information, that's a good thing. We can say, yes, we've got the language, let's implement. So I think I don't want to be ignorant. I want to make an informed decision. So
Thank you.
that makes any sense.
I got Topper, I have Brian, I have our healthcare advocate who's done. I've got Alan, and then I wanted to make a comment afterwards.
I may have to leave you in a few minutes.
Yes. I think I think we'll be okay. Topper?
Is the healthcare advocate gonna be with us?
Not on this.
Well, I thought you said
No.
healthcare advocate.
Well, no, he had raised his hand earlier on the side
I think I'm.
and I shushed him.
I think I tried to answer that question that you just brought up
Okay.
by talking about subsidizing. Whatever is left, if the price is gonna go up for them. So anyway, I think I'm done for right now.
Great.
I
I love the Catamount.
I want everybody to know that, as this thing is setting right now, I can't support it.
This particular section?
Right.
With the, can you clarify for me, can you not support it because of the report back? Or can you not support it?
I can't support it because the way it was originally written
Yeah,
is to have, everything ready and then apply, see if we can get, the waiver from the government. And
And
that's
you
what I
don't need a
want.
waiver on this, to
Maybe
move
I used the
forward.
wrong
Just,
term.
it's okay. Just want to make sure people know. It's just if the federal government changes the law, our law would be ready to go.
We'd be ready to go. And right now, we're gonna do a study and then we're gonna determine whether we're gonna be ready to go. So.
Brian, and then Alan.
Yeah, I guess.
Back a year or two.
Yeah, I thought of another possible way that I could see myself compromising on this section, which would be the analysis and putting the language, passing the language with a sunset. Because if there's a sunset, then it goes out of existence if the legislature doesn't do anything. So it kind of it would put the committee in the future in the position of having to decide, do we remove the sunset and let this go into law? Or do we let it go away? And so it's kind of like we create something and it sits there and it's on the shelf and it's ready to go. And then if it's possible, we just quickly we pass a bill that removes the sunset. It's a very simple action, and then it goes into effect. If we modify it a little in that bill, like, we have something to work with, we fix it up and we remove the sunset. But I would be uncomfortable putting something there that just sits on the books forever.
Can I ask John a question
Yes.
really
Yeah,
quickly, based on yours and
Yeah, yeah.
Topper's? Because I know I only have it for another minute or so. Is there something that would allow DFR to proceed with just rulemaking, but not go into effect so that they could, because I think that's one of their concerns, is that they wanted to start the rulemaking process so that it would be ready to go. Is there a way that we could write it in that they could just do the rulemaking, but then have to come back to us if they were gonna implement it in 28?
What would you do in the rulemaking on?
Well, DFR wanted to start rulemaking in
I think you want to hear
anticipation.
from that. I mean, there's cost and time, staff time, a considerable amount involved in rulemaking. I think it would be unusual to have rules sort of
I just didn't know if we could write that in.
contingent upon a contingency that's upon a contingency. It starts to give a lack of notice to the
Okay.
public about what the law is.
I'm sorry, I've got to go to Alan here first.
Okay, I'm confused again. Okay, so what do we study if we don't know the status of the federal law? What are we're saying we're gonna have a study.
So the study in the version I brought to you today isn't really a study, it's just look at what the federal law says. The language that was just talked about that I've been, working on potential language for is studying the projected impact on our health insurance markets of expanding access to the association plans, including the likely impacts on premiums in the individual and small group markets.
So you answered part of my second question is what is the intent here and what are we trying to accomplish?
Let that be other people.
The chair probably.
I'm sorry, I missed your.
I want to know what our intent is. I think I do because we just answered some of that. But what are we actually trying to accomplish here?
I think that kind of leads me a little bit to the statement I wanted to make. Because I've been listening to this whole discussion and we keep discussing, what's going to happen to the individual market, what's going to happen to the small group market. I mean, the intention of putting this in here, just to answer your question, is because we haven't actually done any analysis of what this is going to do to our market. And before we proceed with possibly upsetting and destabilizing our healthcare marketplace, we probably should have a little bit more information. That's what I think this is about. But
Be back this afternoon.
yes.
Okay.
Well, thank you.
But I guess what I keep thinking about as I'm listening to this whole conversation is, you know, I always talk about how it just seems like all we ever get to do is we nibble around the edges. And we're sitting here talking about, well, maybe we can subsidize this market. Maybe we can, what can we do for this? Maybe here's something that can maybe lower rates for a small group of people, but it might increase rates for others if they do that. I keep coming back to just moving deck chairs around. It's not about the market, it's about the cost of care. And I just feel like we need to be putting our efforts into reducing the cost of care for everyone so that we don't have to sit here and have hour-long conversations around expanding to AHP plans. That's all I guess what my statement was. I want to work on things that reduce costs for the small group market, the individual market, even the large group market, maybe even ERISA plans, although I'd love if the qualified health plan and the market that we have control over to some extent, I would love for that to be the place that everybody wants to be. Because it has lower costs, and I just see this thing on association health plans as people fleeing because the costs are so high. Let's do something about the costs, because that helps everybody.
When you do something about the cost, those people will come back.
That's kind of,
But in the meantime, I'm gonna go where I can feel is the best for me financially and my family.
and I'm concerned that by going with the best that people can find, that they're actually raising costs for other families who are left behind or who don't have a trade or a association where they can pool. You know, I mean, how does this help my guys and their families at an automotive repair business? It doesn't. It raises it for them too. I've got Val, and then I got Lori, and Leslie, and Brian. And then I think we're gonna table this because we've got some other things to discuss. Oh my God, should I just go around the table? Starting with Val. I'm starting with Val.
Yeah, this might be for you, it might be a little more theoretical. So if we did subsidize, say, the individual plan market,
Okay,
we
we do.
to, what we do now,
Might have to substitute them, subsidize them. If,
so then it would not eventually level out. If we're already subsidizing, we're going to subsidize more, then we would know now that maybe in the next year, we wouldn't have to subsidize that. But we do, and now we're thinking of increasing that. How are we subsidizing?
Mike Fisher. I think the question here is not about the individual market. We're doing what we're doing for that, and the lines between the individual market and the group market are are what they are, that have some limitations on people being able to go between. So I think the question here, the committee was asking itself already about what is it that would need to be done to protect the rest of the market if you allow people to leave? And I think that's the subsidizing, the idea of subsidizing the small group. And I'll just add, we opted out of being a shop state a while ago. Many states do have a mechanism for the small group that was allowed in the Affordable Care Act. And I believe some states do a tax credit for those small businesses. And so what I was going to say earlier is if you are wanting to study marketplace stability options, not only is there an actuarial questions involved, but there may also be policy questions involved, other options too.
So you get into waivers?
Can you tell us what a shop state is?
No, because
Again, another thing I have to learn.
because we opted out of it. We originally planned to do it, and then we opted out of it. This is a lot of years ago, and I can't now remember why it was that we opted out of it. But I'm just suggesting, in the context of things to study about ways to support the small group, I would add that to the mix. And I can't say much more about it, but I just don't.
Waivers, how we subsidize now?
There's no subsidy in the small group.
Just individual.
Up to 400%.
Yeah.
So, yeah.
So there's a federal subsidy under 400% on the individual market, and then Vermont has elected to have what's called Vermont Premium Assistance, which then comes in and adds a little bit more based on. And I believe in the market report that there was a recommendation to possibly increase that. And we're talking about the individual market though, not the other one. But there was, and that maybe we're not subsidizing it up to the amount that we could without a waiver. I think. Maybe, not true? Okay, there was a recommendation in there. Okay, I have no recollection of who was in order. So,
Quick little one for Topper.
okay, really quick,
Yep.
but
And I
you're
just.
jumping ahead.
Yeah, it's just a question. When I think about all of this is contingent upon the federal government changing the waiver and saying, yes, you can do these now. My question is it not possible to get the information in the meantime so that if that happens, we are ready to launch? We have the information, we understand it. And we've also had a chance to think about or implement your other suggestion about what to do about folks that might be left behind. I don't know if you have an answer for it, but it's just kind of a suggestion as to they could be simultaneous. That while the federal government's figuring things out, we are also finding information.
That's exactly what I thought
Okay,
the association plan was doing. We were gonna remove restrictions to develop a plan to be ready if the government did do it. We're not gonna do it, can't do it
can't do it yet.
until the federal restriction is lifted. So I just thought it was a way to get ready. Not now, it's what I'm getting a little bit concerned about now is if we're talking about a study and it's gonna cost money, that's gonna hold this whole thing up.
I'm not willing to spend money study, but I'm also not willing to do it without a study, so.
I think so I just want to be really clear because we've gone in a lot of different directions, just pertaining to the association health plans, right? We do not know the effect that this will have on businesses or individuals at this point in time because no data was presented. I would like to ask us to go back to DFR and see if they have the capability within the funding they already have within their budget to do an analysis, which I would hope they would do anyway, to determine what their recommendation will do to the markets. I want to know that, you know, we're saying if it comes back and we're only helping businesses by 1 or 2%, but we're raising individuals by 20%, that's a big deal. Maybe it's the other way, right? Maybe 4% here will mean only 2% here. And then that's great. Let's help the businesses. But like, we just don't know. So outside of subsidies and anything else, I really can only support this if we put in, or at least we talk to DFR about doing an analysis. That's all I'm asking.
So, so Lori, you're suggesting that, we have, if I come in right now. And
I don't know if we need them
ask the question.
right now, but I would like to know that if it's in their, if it is
That's
within
what I
their
mean.
budget to do an analysis.
But we did ask them the question. When they testified originally on this, we asked the question, what about this? What about that? And they said, we don't know.
Right, so did we ask the question? And I apologize if I missed it. Do you have the
We
money
did
in
not.
your budget today?
That we didn't ask. That we did not.
I've asked.
And,
No, I understand.
Oh,
oh, you did. Let us know in 5. Thank you, Nolan.
And can I ask around the room, and I'm sorry because maybe I don't, is DFR represented at all in the room today? Okay. Thank you. Brian.
I don't know what the order is, but you've been going this way, so. Yeah, I just wanted to say that this raises like a philosophical thing that I just want to put out there, that we're talking about creating more choice in a marketplace, which is a mindset of competition. It's this idea that pitting different options against each other is somehow going to generate a better outcome for everyone because they're going to have choice and they're going to be able to pick the best thing. But as we have learned, there's winners and losers, and it doesn't always shake out that way for everyone. And I just want to point out that, like, we are the healthcare committee, that if we look at humanity and we look at human development and evolutionary biology, humans did not survive on Earth through competition. We are a social species who survive as a group. Like, we survive when we band together and we take care of each other. We don't, we see when people are cut off, when they're isolated, they don't do well. We have a, right. So like, and then, right. So then there's groups, and when the groups fight with each other, one wins, one loses. But when groups come together and solve problems together, then we progress. And as a species, we've progressed through collaboration more than our competition. And so our competition teaches us something. There's a place for it. But I think in the healthcare system, having competition between the healthcare plans isn't really the place to put our energy. And I just wanted to, illustrate that, like, we're talking about this assumption that competition is somehow going to generate a better outcome. I think we've learned that that's not always the case. And then the other thing I wanted to say is when it comes to subsidies, my landlord told me advice my business landlord once told me advice that his father told him that comes to mind today. He said, listen, kid, like, it's never really a business expense. It either comes out of this pocket or that pocket. Like, and like what he meant by that is like that, like when I'm thinking about it with the subsidies is like, so we create this market and then we're like, oh, it's going to hurt this piece instead of this piece. So we're going to throw money into this piece to make up for the harm that's coming here. Where's that money coming from? Well, if it's coming from the general fund and it's coming from taxes, then someone's paying that anyway. So in the end, it's like what Alyssa said about moving deck chairs around. I think you said that.
Yeah.
Yeah. So I feel like I appreciate the idea. Like we want to help one piece because we're causing harm to it by creating this other piece. But in the end, it just further illustrates the point that there's all these variables. And I'm really concerned about further splitting people and creating competition without any proof that competition is going to make things better for the overall system. And I don't think the answer necessarily is to then spend a lot more time and money looking at all the different ways we can like plug the holes, with money, because it's just moving money around and moving deck chairs around. So I don't know. I just wanted to say that because I'm hoping we can think more about how collaboration may be a better approach than competition in the healthcare system.
So let's go Leslie, and then I think we're going to take a break. This has been a fantastic discussion, by the way, really. I mean that sincerely. Oftentimes I don't, but I mean that sincerely. I think it's been a great discussion.
This discussion has really been focused on the impact of the association health plans on costs of individual, small group market, et cetera. Qualified health plans are really regulated by the Green Mountain Care Board. We really understand their rules. There's a lot of statute about what they can do. We don't have that structure around associated health plans. We don't know how they operate. And so there's a whole piece that worries me is the interaction of these plans with hospitals and providers of care. So I think it's important for me to know that impact included in this study. So it is beyond the actual insurance world, but it's about the whole system and the implications of adding a sort of unregulated insurer to our system. And I feel worried about that. So I would want to include some information or study that the impact of adding this to the system. And I know we don't want to spend money.
No, I mean, and I was trying to make that point, like, I know that we received some written testimony from a physical therapy profession and their support for the AHP plans. And I'm also thinking about some of the underwriters for the AHP plans. There was one in particular that I spent a year working back and forth with DFR and the Attorney General's office because of unfair contract negotiations with physical therapy. And, you know, so I'm really concerned about that.
Yeah, I don't know.
We don't know the impact.
We don't know. I don't understand how association health plans pay the bills. You know, what is their process? When do they pay? When do they not pay?
Can you kick someone off if they have a pre-existing condition?
I don't understand it. I'm just saying, I'm not commenting on it.
Regulated.
Yeah, I'm not commenting on it. I'm
We
just
have
saying, I don't understand it.
All right, so I think we should take a break until 10:30 and then we're gonna move on. We're gonna take some testimony on the section in the bill as it relates to what used to be, well, it still is, H102 that was inserted in it.
What section's that?
It's around just the reporting from sharing plans. And we're gonna